Okay. So, by brief history of malaria, we consider that the first malariologist is probably Hippocrates himself, father of medicine. And then we've had several factors in the history of malaria as way back as 400 BC, where the Hippocratic corpus distinguished the continuous fever, intermittent malaria fever, from the continuous fever that you have in other infections, like when you have the every third day rise in temperature. Then we've also had other people like Laveran, a French physician, who found an object when he was examining a blood film of a patient, which he later described to be malaria. So global burden, why are we worried about malaria? It has a huge global burden. We've said that malaria has about 239 million cases worldwide as of 2010. And other things about malaria that make us interested in it: 80% of cases occurring here in Africa. And of course, for us in pediatrics, we said children less than 5 years accounting for about 61% of cases. When you look at top 20 killer diseases in children, especially here in Africa and in Nigeria, malaria will be part of it. So we'll skip some unimportant slides. Look at annual cases of malaria in Nigeria. We said malaria, 25% of global malaria burden in Nigeria, and 19% of the global deaths, and then 53% of cases in West Africa as a whole occur in Nigeria in particular. Now, Nigeria made a significant stride in the effort to control malaria. If you know about the rollback malaria program in 1998, it used to be a question when we were in medical school, talk about the factors around rollback malaria. And then WHO also launched a global technical strategy in 2016 to 2030 to have a world that is free of malaria. So let's move away from history and talk about etiology. 5 known species of Plasmodium. I've said that malaria is an infectious disease. And then 5 known species of Plasmodium are the P. falciparum, Vivax, Ovale, malaria, and P. knowlesi. 98% of malaria in most parts of Africa is actually caused by P. falciparum, and that's why you hear a lot of people talking about Plasmodium falciparum. But Vivax and knowlesi also cause some severe malaria. So how is it transmitted? Malaria is transmitted by the bite of an infected female Anopheles mosquito. A lot of times when we're asked to just say it's transmitted by the bite of a female Anopheles, it has to be an infected female Anopheles mosquito, and that is a major mode of transmission. It could be accidental in blood transfusion and needle stick injury. We could also have transplacental transmission, and that's why I said I'm teaching malaria with respect to pediatrics, because for us, congenital malaria is also a form of malaria, and a mode of transmission is actually transplacental. Then the zoonotic infections too. Okay. A bit on the epidemiology. More than 40% of the world's population is at risk of malaria. We have about 90 countries in Africa affected by malaria, other parts of Asia, South and Central America. P. falciparum occurs mainly in tropical areas where warm weather. Warm weather is found to be good for the breeding of malaria, so that favors transmission of the disease. Vivax has a wider geographical distribution in both tropical and temperate regions. Ovale, found in sub-Saharan Africa, and P. malaria actually has the least common in terms of coverage and epidemiology. So the endemicity of malaria, you classify it in different ways based on the spleen and parasite rate. You could say it is hypoendemic, or mesoendemic, or hyperendemic, or holoendemic. Then based on transmission rates, you could have high or low transmission areas. Then you could even have malaria-free or zero cases. And for Nigeria, we're in the high transmission area. So a bit on the life cycle of malaria. To describe the life cycle of malaria, it has the sexual stage and the asexual stage. So the sexual stage occurs in the female Anopheles mosquito, and that is what provides the sporozoites to the host. Sexual in the mosquito, asexual in humans. Okay, so I'm sorry about this, honestly. I don't know why my slides are not able to make it in a slide form. But the life cycle of mosquito, like we said, the asexual stage is the one that I said occurs in humans. And look at how it begins from the bites of an infected female Anopheles mosquito. When the mosquito bites, what it does is to release infected sporozoites. These sporozoites travel through the bloodstream and enter into the hepatocytes. Hepatocytes are liver cells. They multiply and proliferate there in the hepatocytes and then release schizons. Now, these hepatocytes will now burst and release merozoites, or the pre-erythrocytic schizons, and then complete the tissue phase. Merozoites will eventually enter the bloodstream and then mature to the ring-form trophozoites. So it's just that part of the cycle that occurs in the humans. From the point it bites you, releases sporozoites into the blood, they travel into the bloodstream, the liver, they multiply in the liver cells, and then release schizons, burst out of the liver cells again, back into the blood, and then mature to ring-form trophozoites. Now the trophozoites mature into the erythrocytic schizons. Erythrocytic means that they now infect the red blood cells. Now these erythrocytic schizons will further divide into merozoites within varying periods of time, and the merozoites would release into the red blood cells, will repeat the process with varying degree of parasitemia. And that's why in children we talk about, as we will later see, the level of parasitemia as one of the features of severe malaria. And these merozoites will release toxins that are derived from these hemozoin, which are actually part of the factors that influence the severity of the malaria. Then the sexual stage, which we say occurs in the mosquito, occurs from the point the gametocytes are ingested during a blood meal. By the time the mosquito comes to bite, it picks up gametocytes, which is a stage in the cycle of the parasites. Then male microgamete fertilizes the female macrogamete. Remember, the male is the micro, the female is the macro, and then they form a zygote. The zygote, which we call ookinete, will later form an oocyst in the stomach of the mosquito. The oocyst will grow and then rupture and release sporozoites. These sporozoites will now enter the salivary gland of the mosquito and is released during a blood meal. So what does the mosquito pick from our body? It picks gametocytes. Gametocytes, male and female, fuse the zygote to oocyst, and the oocyst rupture to give sporozoites that go to the salivary gland of the mosquito, and then it releases it back into the human during a blood meal, and then in from the human through the blood to the liver, and the cycle continues. Okay, so just a bit on what I just said. So I'll just take it again in a way we'll grasp it better. Look at the bullet points in their sexual phase. Bite from a female Anopheles mosquito. Sporozoites inoculated into the bloodstream by the Anopheles mosquito. They migrate within minutes to the liver. They invade hepatic parenchymal cells. Within the hepatic parenchymal cells, they will undergo asexual multiplication, and which is what we call hepatic schizony, and then form schizons. Schizons in the liver will rupture the liver cells and release merozoites into the bloodstream. I hope we are getting this. Well, in exams then it used to be like MCQ questions. Sound a bit simple, but then can be a bit confusing when they are twisted. So this multiplication within the liver cell will produce thousands of merozoites from each sporozoites that have infected the liver cells. And this process of schizogony lasts 7 to 10 days for P. falciparum, vivax and ovale, and 10 to 14 days for P. malaria. Now, these merozoites that are released by the ruptured hepatic cells will now invade red blood cells, where they will asexually multiply and undergo differentiation to male and female gametocytes. I don't know if this is clear. So I don't mind if we echo some of my questions. So when the mosquito bites the human, what does it release into us? I want to be sure you're listening. Can you hear me? Am I being heard?
Yes, we are hearing you. Please, we need answers, so let's be sure that we are communicating.
Okay. So I was asking, I said when the mosquito bites, what does it release into our bodies?
Sporozoites.
Okay, sporozoites. Then the sporozoites travel to what part of our body?
The liver.
Good. So it travels to the liver, invades our hepatic parenchymal cells, then multiplies in those cells. Multiplication, I said, is asexual multiplication, and then forms what? Schizons. So sporozoites enter liver, form schizons. They will now rupture the liver cells and then release what into our blood?
Trophozoites.
What do the liver cells release? No, they release merozoites first. Now, these merozoites will now infect the red blood cells. The merozoites that were released by the ruptured hepatic cells will now invade the red blood cells. Okay? So I'm just trying to go through it so that we are sure that we are following the process, and then undergo multiplication into what you have mentioned, and as well as into... Pardon? I didn't get that. I didn't get that, sorry. Did somebody say something? Okay, so let me continue. So the sexual stage begins from the point that the male and female gametocytes are ingested by the mosquitoes, which I said before. Then I said these gametocytes, I already said the male was a microgamete, and then the female, which is a macrogamete, fuse to form a zygote. Now this zygote, or what we call an ookinete, will rupture to release numerous sporozoites that will migrate through the mosquito. They enter the salivary glands, and then they are released into humans when they take a bite, what we call a blood meal. Okay. All right. So pathophysiology of malaria. Looked at it from several angles. The erythrocytic schizogony, which is the point at which they invade the red blood cells, release merozoites into the blood, release malaria toxins, and these toxins are actually plasmodium-derived hemozoin and glycosylphosphatidylinositol. These are just, and then they activate macrophages and endothelial cells, release cytokines and your inflammatory mediators like tumor necrosis factor, interferon, interleukin-1, interleukin-6, interleukin-8, and all these inflammatory mediators. And that causes most of the systemic manifestations of malaria that we see. So Due to rupture of the red blood cells and the release of merozoites into the blood, you have fever and chills and malaise seen in all forms of malaria. All forms of malaria go through the inflammatory process, release of inflammatory mediators, and all of that. Now, these red blood cells that have been infected by Plasmodium get opsonized with antibodies or complements, and then they become trapped in the spleen, leading to splenomegaly, anemia, and thrombocytopenia. Of course, the body probably recognizes these red cells that are infested with Plasmodium as infective agents, and so they get into action, and then they try their opsonization and phagocytosis, and then the spleen, which is actually an immune organ, comes to play, and most of those are stored in the spleen, and that's why I have splenomegaly. Due to the splenomegaly is due primarily to splenic consumption of red cells and platelets. They also have autoimmune hemolysis. They play a role in the continued destruction of red cells. So the red cells, autoimmune means that the body is producing antibodies that are damaging its own tissue. Because the red cells have become infested with parasites, then antibodies by the body come into play and then cause destruction of those red cells. And this also has a role to play in the pathophysiology of anemia in malaria. They also have some organ dysfunction, which can be due to cytoadherence of the parasitized red cells to capillary endothelial cells, and then antigen-induced cytokine production. Like I've said before, these are roles of inflammatory mediators. So when you have some of these infested red cells getting sequestered in the capillaries, so you have a process whereby all the inflammatory mediators come into play, and then you start having organ dysfunction because of local tissue ischemia and hypoxia, and major organs like the kidneys, the GIT, the lungs, and the CNS complications, especially with P. falciparum. And this you may not commonly see in adult medicine, but it's things that you commonly see in pediatrics. I remember about 2 years ago, I had a little boy that was referred here, and the referral letter said intussusception. So when he came in, I thought it was a surgical case, but I just said, okay, let's just quickly do our own scan and see if it's intussusception. And the scan said there was no intussusception, but there was what looked like paralytic ileus, and so we just admitted him and then just started antibiotics for whatever it is. Okay, why was his abdomen a bit distended? Why was this looking so toxic? Lo and behold, malaria for us is like routine tests. We just do for patients that come in. We do full blood count, malaria parasite, and then lo and behold, one lab scientist came from the lab and was looking, who is the doctor that sent for this test? And I was like, okay, I'm the one that sent for the test. He said, okay, I just wanted to tell you that your patient has 4 clusters of malaria. In my life, I've never seen 4 clusters. That was actually my first time. And then it was then I dawned on me that that child was actually having severe malaria, and he was already having a lot of organ dysfunction. He was having some altered sensorium, was having abdominal quite dramatic in children. So we'll list pathophysiology in several bullets. The parasite biomass, the microvascular obstruction that could occur, like I said, cytoadherence, that's adherence of these parasitized red cells to capillaries, sequestration of parasites in various organs, and with certain red cell membrane rigidity. The red cell membranes are supposed to be pliable such that they could meander through capillaries. But when there is endothelial cell dysfunction, you find that they become rigid and they are not able to travel the way they should. And so you see patients begin to have hypoxia, because what does the red cell do? It helps to transport hemoglobin. Okay, so clinical manifestations of malaria, especially in children, would include You have uncomplicated malaria, which will have a clinical course with fever and other symptoms. But note the incubation period, P. falciparum for 9 to 14 days, Vivax and Ovale 12 to 18 days, then malaria for 18 to 37 days. Now, for uncomplicated malaria, it could occur in several ways. And that's why you see in Nigeria, people say the only sickness Nigerian doctors can treat is malaria. We don't blame them. It's because we have a heavy burden of malaria. And so when you see somebody coming with constitutional symptoms, of course, you have to treat malaria first before you investigate for other things. But that does not mean that you want to be a malaria doctor. So clinical features like fever, headache, nausea, vomiting, you can have diarrhea from malaria. You could have myalgia and arthralgia, that's muscle and joint pains, malaise, child just feeling unwell, cough, excessive crying, sleep disturbance, jaundice, pallor. All these are clinical features of malaria. Now, for severe malaria, which is for us in pediatrics, a killer disease, and and it's also for us a medical emergency. So in severe malaria, you have one or more life-threatening complications, which could be clinical or laboratory, in the presence of asexual forms of P. falciparum. 95% of cases are caused by P. falciparum. You could also have Vivax and Nolesi. So who are the groups at risk of severe malaria? It is children in high endemic areas like ours. And that's why we emphasize that children under 5 should sleep under a mosquito net, especially in our environment. I know we have always said children under 5 and pregnant women, but we're in pediatrics, so we're talking about children, especially those under 5. But suffice to know that at my age, I still sleep under a mosquito net. Why? Because I am, working and living in Gwagwalada, and so far I've realized that we have too many mosquitoes in Gwagwalada. I don't know about the major town in Abuja, so I sleep under a mosquito net. So if I would sleep under a men, why would an under 5 who is more at risk not sleep under a mosquito net? So we'll have people of all age groups in hypoendemic areas. You have non-immune pregnant women, like I said, travelers, then splenectomy. Splenectomy is something we encounter, especially in our children with sickle cell, when they begin to have frequent splenic sequestration crisis. It becomes really troublesome and they keep coming with anemia. At some point, we just say, okay, let's take away the spleen. So they become at risk for even a higher malaria burden, because I've said spleen is actually an immune organ. Okay, so I said that malaria has clinical and laboratory features. So the clinical features of malaria: impaired consciousness. This you would see commonly. You see a child coming with a Glasgow Common score less than 11 or a Blantyre score less than 3, or prostration. A child is so weak that he or she is unable to sit, stand, or even walk without any assistance. That's prostration. Multiple convulsions, when you have more than 2 convulsions in 24 hours. Significant bleeding. A lot of people tend to ignore this part. I've seen at least just one case some years ago. Child was just bleeding from the mouth, and we're thinking of leukemia or viral hemorrhagic fever. Lo and behold, it was 3 pluses of malaria. So it's not something you see commonly. But remember, we talked about affectation of platelets and red blood cells. And so that thrombocytopenia, which could complicate severe malaria, could present with significant bleeding. And then respiratory distress as part of organ dysfunction, and rapid, deep labored breathing. All these are clinical features. A child with severe malaria could come in shock with a capillary refill that is more than greater than or equal to 3 seconds, or no hypotension. But when they are decompensated and they begin to present with hypotension, when you have a systolic blood pressure less than 70 millimeter mercury in children or less than 80 in adults, with evidence of poor perfusion. By poor perfusion, we mean a child with cold extremities, with prolonged capillary refill. We don't expect our children to have a capillary refill that is more than 2 seconds. So when they begin to have a capillary refill 3 seconds and above, for us, they already have a poor perfusion. And so the shock that they may come in may be compensated if there's no hypotension, or decompensated if it comes with hypotension. Then jaundice is also a clinical feature that we look out for. Laboratory parameters include hypoglycemia. This is really quite common, surprisingly, in children. You have them coming with a random blood glucose that is less than 2.2 millimole per liter, or 40 milligram per DL, and that's hypoglycemia. You need to correct urgently because the child may die faster from hypoglycemia or convulse from hypoglycemia even before dying from malaria in itself. So severe anemia, when the HB is less than or equal to 5 grams per DL, or PCV less than 15% in children, less than 12, or when it's less than 7 grams per DL or PCV less than 20% in adults, with a parasite count greater than 10,000 per microliter. Well, why this is important is, well, it's not all the time that we see children with HBs less than or equal to 15. Or sometimes we see them with HBs, say PCV, say 18, with hyperparasitemia. We already know we're dealing with malaria. Sometimes we do not have to wait till it is 15 to say, oh, this is severe malaria, and we have to treat as a severe malaria protocol. Then renal impairments, yeah, something you see, sometimes when you begin to have an elevated serum creatinine. Sometimes you have to note these figures. They are things that we memorized. We have memorized over time. 265 micromole per liter, or 3 milligram per DL. Or you have a blood urea more than 20 millimole per liter. So that would suffice for renal impairment. Sometimes, even when you have not done your electrolyte, urea, and creatinine, and you have children that are not making adequate urine, their urine output is about 0.5 ml per kg per hour in the presence of 2 or 3 pluses of malaria, fever, and anemia, you already know you're dealing with severe malaria with complications. Acidosis, you have base deficits more than 8 milliequivalent per liter, or if not available, you have a bicarbonate less than 50 millimole per liter, or venous plasma lactate, which we don't commonly do here, greater than 5 millimole per liter. We talked about jaundice as a clinical feature, but in the lab, when you have serum bilirubin above 50 micromole per liter or 3 milligram per DL, and a parasite count over 100,000 per microliter, then that would fulfill the criteria for severe malaria. Then hyperparasitemia, which is common in our environment, when the P. falciparum parasitemia is more than 10%, or malaria parasite density of over 200,000 parasites per microliter of blood in a hyperendemic area, or if you have a parasite density more than 100,000 per microliter in a hypoendemic area. So whatever it is, this works mostly for areas that they do a proper thin film, for parasites, thick film for, you're supposed to do thick and thin film. When they do a proper parasite count, that's when you can actually say what the parasite density is. But in our environment, most times what they do is they either give us 1 plus, 2 pluses, or 3 pluses. So if they can do a proper parasite count, that's when you'll be able to define using that criteria. Now, cerebral malaria, which is a common killer disease in children, is the most severe neurologic complication of malaria. And what you have motor response to noxious stimuli is non-localizing or is absent. I have malaria with coma persisting for over 30 minutes after a seizure is considered to be cerebral malaria. And you have excluded other encephalopathies. It means that this coma is not attributable to alcohol ingestion, is not attributable to any drug overdose or meningitis or any head injury or cerebrovascular accident. And you know that this coma, which has lasted over 30 minutes, is in the presence of a positive malaria parasite test, then it is likely to be cerebral malaria. How do you confirm? You have asexual forms of P. falciparum must be demonstrated. asexual forms of P. falciparum must be demonstrated in the peripheral blood or bone marrow smear of that patient before you can say that this is cerebral malaria. You must also have altered consciousness with a GCS less than 11 or Blantyre coma scale less than 3. So what are the neurologic features of cerebral malaria? You have coma, convulsions, nystagmoid eye movements, conjugate eye deviation, excessive salivation, abnormal posturing, and abnormal tones. These are all neurologic features that you may see with cerebral malaria. Differentials may be meningitis and encephalopathies, viral encephalitis, sepsis or diabetes mellitus, epilepsy, acute kidney injury. All these are possible differentials of cerebral malaria. And also things like viral hemorrhagic fevers, COVID and stuff. So national guideline for diagnosis and treatment of uncomplicated malaria. This is very important. A patient who has fever or unexplained systemic illness has traveled or resided in a malaria endemic area within the year should be evaluated for malaria. And why do you want to confirm a diagnosis of malaria? Number one, you want to improve the chance of recovery of the child. You want to reduce over-treatment. You want to reduce the chances of treatment failure. You want to reduce wasting resources in terms of time and money. You want to reduce the risk of drug resistance and then give users confidence in the health worker. So the policy, according to our national guideline, is that all suspected cases of malaria should have a parasite-based confirmation before you institute an anti-malaria treatment. I know we are all guilty of this. Even if my child, despite the fact that I'm a doctor and I know what the national guideline says, if my child has a fever, the first thing I do is to give an ACT, even without running a test. But we should know that that is actually not correct. The national guideline is proposing that we treat when you can demonstrate a parasite-based confirmation before you initiate anti-malaria treatment. So I want to take history and information, like where they live, where they have traveled to, do they have fever, chills and rigors, headaches, and all of that. And then you examine, you're looking out for temperature, for paleness, CNS signs, like we have talked about seizure, coma, and all these neurologic features we had mentioned earlier. Don't check the respiratory rates for any signs of respiratory distress. Want to palpate for the liver and spleen and rule out all other causes. Of course, you should know that if a child is brought into the ward unconscious and while examining the child, you smell sniper, then you should know that you will not be thinking of malaria first, but you'll be thinking of maybe organophosphate poisoning. So that's the essence of a general overview of the child before you start thinking about malaria. So investigations, we have non-microscopic tests, which involves identifying the parasite antigen or the antibodies or the parasite metabolic products, like your rapid diagnostic test. Then we have other tests that we carry out. So this RDT we keep talking about, we do it all the time. So what it does is that it detects specific antigens, which are proteins produced by the malaria parasite. These antigens are currently present in the blood of infected or recently infected people, and it signifies their presence by a color change on nitrocellulose strip. Even here in our emergency, what we commonly do, we're doing microscopy, but because of the high burden of patients, when we want to do microscopy, we send to the lab. But for us, we do a rapid diagnostic test. So, there are other tests that we do. Let me skip this. You can also do a blood film microscopy, like I mentioned, the thick and thin smears are usually prepared. So they are Giemsa stained thick blood smears at the basis. Sorry, please. Giemsa stained thick blood smears are the basis for microscopic diagnosis, with a standard of looking at 100 fields at a magnification of 600 to 700. Which is about 0.25 microliter of blood. So for the microscopy, you just need a drop of blood. And what it involves is staining, and you do a direct visualization of the parasite under the microscope. Now, we hear a lot about 1+, 2+, 3+, 4+, and I'm sure not many of us know what it means. But before I go there, remember that the thick blood film is used to identify the parasite and to tell the density. And then the thin film does speciation, okay, and then density. So density, which is parasite density, which is semi-quantitative, which is what a lot of labs do and are used to. So WHO has a plus system, which even though it's less accurate and it's also prone to misinterpretations. For example, a lab scientist, Chelma may come and say it's 2 plus, lab scientist Timothy will say it's 1 plus on the same sample, and that is why sometimes it can be viewer dependent, and it also may be due to affected by expertise or skill. So when you have 1 to 10 parasites per 100 high power field, then it's 1 plus. And you have 11 to 100 parasites per 100 high power field, is 2 pluses. When you have 1 to 10 parasites per high power field, is 3 pluses. Then you have more than 10 parasites per high power field, it is 4 pluses. I've actually seen only one patient in my practice with 4 pluses. That child was a very, very, very sick child, but I thank God that child was able to make it alive. So, okay, I talked about microscopy and the plus system. Okay, then we also have fluorescent microscopy, where we'll do a quantitative Buffy coat method, the Kwamoto-Acridine orange process, the benzoyl-thiocarboxypurine procedure. All these are just some of the forms of microscopy that they carry out in the laboratory for malaria. Now, these pictures just illustrate what they are talking about, but I'm sure it's clearer to the scientists. So this is blood mixed with acridine orange, centrifuged, and then is read directly with a fluorescent microscope. We also have other forms like the polymerase chain reaction. You can detect less than 5 parasites per microliter with 100% sensitivity and specificity. But trust me, nobody really does a PCR for malaria around here, but it's important to know that you can do polymerase chain reaction for malaria. You can see the sensitivity and the specificity is 100%. Then the immunochromatographic test, which detects circulating antigen of P. falciparum, takes about 8 minutes. Then the intraleukocyte malaria antigen. There are new options which we should just know for academic purposes. The optical sensors for malaria tests, the LAMP, which is loop-mediated isothermal PCR, and there's a malaria detecting gum that could offer cheap new ways to diagnose or monitor. Then you're also thinking about ways forward urinary malaria parasites, where we don't even need to take blood or can identify parasites in the urine of patients. So in terms of treatment, what is the goal of an anti-malaria treatment? What's the goal? 2 things. There's a primary goal, which is to cure the patient and reduce prolonged morbidity and prevent mortality. And number 2, which is the secondary goal, is to ensure rational drug use and prevent the development of anti-malaria drug resistance. You can see WHO just keeps emphasizing rational drug use, meaning they want you to actually be sure that it is malaria before you give an anti-malaria. So for anti-malaria combination therapy, the concept of this was based on synergistic or additive potential of 2 or more drugs to improve treatment efficiency and to decrease the development of resistance. So you have treatment of uncomplicated P. falciparum malaria. We have the use of the artemisinin artemisinin-based combination therapies. We have artemether-lumefantrine, which we commonly use. Artemether-lumefantrine is your Coartem, your Lunat-DS, your Lokmal, and all of that. Those are artemether-lumefantrine. We have artesunate amodiaquine. That one is your camosunate. Okay, then artesunate mefloquine is one drug that we don't commonly give to children. Dihydroartemisinin piperaquine is like your P-alaxin. Once in a while, we give to children, even though it's not so well tolerated. Then we have artesunate sulfadoxine pyrimethamine. All these are artemisinin-based combination therapies. So we have two different drugs acting at different sites, producing a synergistic effect that prevents in the long run better efficacy and then prevents drug resistance. Then a child has anti-malaria. Remember all these regimen. A child is 5 to 14 kg, give one tablet. Remember that most artemether lumefantrine for children come as 20-120, 20 milligram for artemether, 120 milligram for lumefantrine. So say 20-120 when they are 5 to 14 kg. When they are 15 kg, you start to give 2 tablets, which is 40-240. When they get to 25 kg, you give 3 tablets, which is 60-360. And once they are over 35 kg, you give 4 tablets, which is 80-480. In the market now, you have drugs that are 80-480, and they come as single tablet for adults like us and for children that are above 35 kg. So we give them same dose as adults dose. You also want to give antipyretics. You don't want to leave a child uncomfortable with temperatures higher than 38.5. You want to give paracetamol. If the child is vomiting, you may want, if the child vomits the medicine, you repeat it. If a child vomits again, you may want to give parenteral drugs that stop vomiting in the child and give appropriate fluid therapy. If the child has seizures, then you have to consider other things, because malaria can give you febrile convulsions. You may want to give anticonvulsants and then follow up. You counsel the patient to return immediately if condition worsens, and then check that the patient completed his regimen. And you also want to rule out other causes, do a blood smear, and also refer appropriately. That's acute or complicated malaria. But you know, in children, sometimes we admit children with acute uncomplicated malaria. If a child has profuse or persistent vomiting, we may want to admit to administer IV fluids. Then for severe malaria, this is life-threatening, which you have said before, and the first goal of treating severe malaria is to prevent death. To prevent death. There's nothing else. This child just does not have to die. And the second one is to prevent recrudescence, transmission, or emergence, and you want to prevent disabilities. If a child has had cerebral malaria, some of them actually recover with some neurologic disability, which you may need to manage with physiotherapy. We've had a lot of children like that, to even get them to sit and walk like they used to before they fell sick. So principles of management, you have first, immediate resuscitative measures, a quick history. It's not when the child comes in and saying, what kind of bedroom do you live in, a 3-bedroom flat or 4-bedroom flat? That's not a time to ask irrelevant questions. Immediate resuscitation, a quick history. How did it start? This is why you're resuscitating the child. Then you start your definitive treatment as urgently as you can. Then when you have started treatment, you can now comfortably take a detailed history and physical examination. Then give supportive treatment and treat complications. Then essential nursing care, laboratory and regular monitoring. Then you assess recovery and discharge. So how do you resuscitate? ABC, your airway, is it patent? Check for airway patency, breathing, circulation, dehydration. You want to assess the level of dehydration in the child. You want to record vital signs, the respiratory rate, and all of that. All these will be part of your acute resuscitative measures. Now, you want to obtain an IV access. For severe malaria, you need an IV access. Take baseline investigations like your PCV, your random blood sugar, your electrolytes. If you may even want to do a lumbar puncture in that child to rule out other problems. Then the first line drug for treating severe malaria is IV artesunate. IV artesunate is given in those above 20 kg. We give 2.4 milligram per kg IV bolus. Then we repeat in 12 hours and then repeat in another 12 hours to make it so that the child gets 3 in 24 hours. So it starts 12 hours and 24 hours. That's how it's prescribed. And for children less than 20 kg, we give 3 milligram per kg per dose in the same manner. Okay. After which we now complete a full 3-day course of the artemisinin-based combination therapy. Second line for severe malaria is IM artemether. IM artemether is given 3.2 milligram per kg IM on the first day, and then 1.6 milligram per kg daily for a maximum of 3 days. After which you still give a full course of your artemisinin-based combination therapy. The third line is IV quinine. IV quinine is, I'm sure the adults do this more. We don't commonly give our children quinine these days. In fact, I don't think I've seen any quinine administered in our emergency pediatric unit for years now. But if that is what is available, you may find yourself practicing in a community where you don't have practicing it immediately available. You may want to give it, but you must know how it is given, so that you don't go and push quinine into a child and then the child dies and then you say the child died from malaria. So you give 20 milligram per kg of quinine. So, as you give it diluted, okay? You give it quinine at a dose of 20 milligram per kg as a loading dose. You dilute in 60 to 100 milligram per ml. For those who are giving IM, you may give it diluted, but of course in children we don't commonly give IM quinine. This is just something I want to know, but let's talk about the IV first. 20 milligram per kg of quinine as a loading dose. You dilute it in 10 ml per kg of 10% dextrose water and give over 4 hours. Please, I'm begging that nobody takes quinine and pushes directly into somebody's vein. The person will die, and they will likely say that it is malaria that killed the person and not our wrong administration. 20 milligrams. So if a child is 10 kg, it means you want to give 200 milligrams of quinine, and you are putting it in 100 mils of 10% dextrose water. 20 times 10 is 200. I'm assuming that the child is 10 kg. 10 times 10 is 100, so 100 mils of dextrose water. You put it and you give it over a period of 4 hours. By the time you give it that way, it is better tolerated. Quinine causes hypoglycemia. The hypoglycemic effect will be less. The tinnitus and all the neurologic symptoms that quinine may cause will be less. Then, after 8 hours, you give 10 milligram per kg infusion over 4 hours again. You give it every 8 hours until the patient is able to tolerate orally. Once the patient can tolerate orally, change to your oral ACT. So the loading is 20 per kg. You give over 4 hours. 8 hours after, you give 10 ml per kg, still in 10% dextrose water. And each of the infusions are given over 4 hours, but you'll be giving it 8 hours until that child can tolerate orally. There is room for giving it as a fourth line, IM. And you still give in dilute 60 to 100 milligram per ml. Okay, dilute it with injection water and give IM. But I haven't seen this practice in the pediatrics. I do not advocate it, but it's always good to know how these things are done. And then there's still room to give it 8 hours until the patient can take orally. For severe malaria, you need to correct. You need to learn about how to give blood transfusion in children. In adults, they just hang a pint of blood. For us, it's different. The blood we give to a 6 kg will definitely not be the same amount of blood we give to a 20 kg child. So in pediatrics, all we do is calculate and calculate and calculate. Okay, so transfusion for those who have severe anemia, for those who have severe acidosis, we give sodium bicarbonate. This is another drug we give in double dilution. We dilute with water and give slowly. If the child has acute kidney injury, we may want to, of course, challenge the kidneys with 20 ml per kg of normal saline and then give it twice and then give furosemide. But if the kidneys are not responding, of course, you now switch to management of acute kidney injury, which is a topic of its own, where you now begin to restrict fluids. You may start considering hemodialysis or peritoneal dialysis. If the child is unconscious, you manage as an unconscious patient. Hyperpyrexia, I said do not leave any child uncomfortable with fever. You give antipyretics. For those in shock, of course, we resuscitate children in shock. Convulsions, we give anticonvulsants. For pulmonary edema, you may position the child with head elevated at 45 degrees, put the child on oxygen. You may give a low dose of furosemide to reduce the preload and then restrict IV fluids and monitor your inputs and outputs. If there's coagulopathy, you can transfuse with fresh whole blood and give vitamin K. Other supportive management like blood pressure management, fluid balance, monitoring the level of consciousness, paracetamia, and all of that. So all the supportive care. Then you assess the child to see how she fares for recovery. Sorry, my slides are not opening. I'll just continue. Okay, so you want to assess for possible residual effects of disease or treatment. Assess the child's vision and hearing, especially a child that has cerebral malaria. You want to schedule a visit for follow-up. I've also had a child who has severe malaria and then has some psychotic manifestations when she recovered from cerebral malaria, which we needed to even call in the mental health physician. So you will have a barrage of symptomatology around cerebral malaria. Okay. Sorry.
We're not hearing you, Dr. Vivian.
Can you hear me?
Yeah, we can hear you now. We can hear you now.
Okay. So I was talking about drug resistance. I said WHO defines resistance to anti-malaria as the ability of a parasite to survive and multiply despite administration and absorption of medicine given in doses equal to or higher than that which is recommended, but within the tolerance of the subject, provided drug exposure at the site of action is adequate. So it means that you have given the right dose or even greater than the right dose that is recommended for the child, or still the strain of the parasite is able to survive and even multiply, provided you are sure that there is drug exposure at the site of action. So that's what and that's one of the things that the WHO is trying to prevent. And then there are malaria vaccines available. We talked about those who are at risk that need chemoprophylaxis. Not everybody needs it. Sickle cell, travelers, immunodeficient, then general prevention of malaria, general health promotion, which is good nutrition, exercise, personal hygiene, specific protection, which is vector control, use of PPE, hand washing, intermittent preventive therapy. This is especially for pregnant women, vaccination, chemoprophylaxis, early diagnosis and treatment, which is to treat the uncomplicated malaria, limit disability after you manage severe malaria and its complications, and then rehabilitation. So thank you very much for listening.
Thank you, Dr. Vivian, for the lecture. I don't know if we have any questions. Well, if we have any questions, let's kindly ask her. Any question, any comments, contribution, let's kindly ask her. Okay, in the absence of any question, please let's thank Dr. Vivian Please let's just thank Dr. Vivian. We can kindly thank her for the
Thank you,
lecture.
doctor.
Thank you, Doctor.
Okay. Dr. Vivian, once again, thank you very much. We appreciate your effort in this lecture. And it's not easy, even despite your busy schedule, able to create time to lecture. Once more, thank you very much. We appreciate you.